Hello, everyone. So now we've learned the basics of mitral valve repair of P2 prolapse for the treatment of type 2 primary degenerative mitral regurgitation. Sometimes, particularly outside of the continental United States, patients have rheumatic heart disease, and that is type 3A restrictive pathology, or type 3B is associated with heart failure and restriction of the leaflets, a very different mechanism. And sometimes in that case, replacement may be preferred. Traditionally, that's done through an open sternotomy, but it is actually ideally suited in an isolated format to be performed robotically. So let's have a look at mechanical valve replacement and tissue valve, mitral valve replacement performed robotically.
Sometimes mitral valve replacement may be more appropriate than mitral valve repair. This is usually reserved for patients with restrictive disease, either type 3A, rheumatic, or type 3B, restrictive due to ischemic disease. This is a 56-year-old gentleman presenting with congestive heart failure, history of coronary artery disease, with type 3B disease. One can notice the restrictive nature here. The anterior leaflet is first divided, starting at the commissure. But then preservation of all of the core groups by first dividing the anterior leaflet in its midpoint with minimal shaving or development of this residual piece of anterior leaflet, and then placement of the cord groups so that they aligned appropriately, and the first stitch to be placed from the ventricular side, where we place all of our sutures, by the way, that incorporates this cord group. And then subsequent to that, our annular bites are utilized to incorporate all of the tissue in a circumferential fashion. Now, it is important to note that the reason we don't use pledgets as our preference is that we want to optimize and get the largest valve possible. Another reason why we approach this from the ventricular side as opposed from the atrial side. And as you'll note, in the anterior leaflet area, I use the anterior leaflet as its own auto-pledget, if you will, by folding the residual component on itself to have extra strength with the tissue, similar to what we do on the posterior leaflet. So the surgical principles remain the same. As you'll note that once we go past the midpoint or the noon on the clock face, I'll switch to my left hand to do the sutures backhand. This allows the camera to remain coaxial along all of the stitches, so there's not entanglement, and it helps my tableside surgeon to help keep suture organization quite nicely. Now, your tableside could be a surgeon or a physician assistant or whatever is the institutional norm. In this case, it's my long-term colleague and partner, Dr. Lawrence Way. As you can see, we have a total cord sparing setup, and then place the sutures extracorporeally, take the valve off of the holder, and deliver that in together. The important thing is that this is a two-person approach where we work collaboratively to align the valve so that suture placement can be coaxial. As you can see, I tilt the valve so that it aligns well, and holding the suture fasteners so that the next bite becomes easier. And this valve is a mechanical prosthesis. You can obviously, this is the Onyx valve. Again, I have no affiliation to any industry. but this is the equivalent of a 33 prosthesis. And that completes the mitral valve replacement. So fairly straightforward. Again, anti-anatomic in terms of its positioning. Always remember to place the vent across the valve for weaning and then pull the vent back. You see the leaflets moving in a normal fashion to complete the mitral valve replacement with minimal gradient of 4 millimeters of mercury. This next case is a bioprosthetic mitral valve replacement in a 75-year-old patient who presented with atrial fibrillation with rapid ventricular response, congestive heart failure, and somewhat decompensated state with rheumatic disease. It may even have some merantic endocarditis, as you can see there, but essentially rheumatic disease. A biatrial Cox maze has already been performed, as you've already seen previously in a previous video. And now we approach this valve. You can see the valve is not large in terms of its overall circumferential size, but you can see very typical rheumatic disease with mixed stenosis and regurgitation as the pathology, but largely stenosis with very thickened cords. And this is quite typical for rheumatic valvular heart disease, as many surgeons and cardiologists that may be watching know very well. I tend to truncate these at the tops of the papillary muscles, but not through the papillary muscle. And this is already very well anchored. In rheumatic disease, there's often not a huge reason to do total cord sparing. Likely posterior sparing should be sufficient, since the cords are so fused between the anterior and posterior cord groups that essentially does the same thing for these posterior preservation techniques to preserve all papillary muscle continuity. Again, as shown in the previous case, I'll fold the anterior leaflet over on itself to create its own autopleget. This is important, particularly in this anterior suture line, because it's usually less robust than the posterior. Again, once I've crossed the midpoint or noon on the clock face, I'll switch to the left hand. I tend to use my DeBakey as a needle driver and a dual purpose, as I believe we've shown previously. Again, keeping the camera in its central point so that the suture management can be easily performed, and then switch back over to forehand once in the midpoint or at 6 o'clock in the clock face to complete the circumferential suture placement. The sutures are then placed extracorporeally. We strategize on where the posts will lie. We pass a sizer. In this case, this was a 29 bioprosthesis, I believe. And note that the commissural posts are placed in a very specific way, that I leave the holder on to help facilitate suture placements. But in bioprostheses, and these are for the trainees in the audience listening or watching, that, as I mentioned in some of the annuloplasty cases, that the markings are for the commissures, and we have to be careful. So I usually rotate this approximately 10 to 20 degrees, and that avoids post-obstruction in the left ventricular outflow tract. And this completes the bioprostheses, again placing the vent across the valve to facilitate weaning from cardiopulmonary bypass, and this demonstrates pretty standard mitral valve replacement.
So now we've seen how to perform robotic, mechanical, as well as bioprosthetic mitral valve replacement. Let's reflect for a moment on all that we've seen so far in this season. These are the fundamental building blocks to begin a robotic heart program, starting from exposure, cannulation, preparation, docking, left atrial opening, left atrial closure, myxoma resection, fundamental mitral valve repair, and replacement. So join me for the next season, where we're now going to take the next step. And we're going to talk about different surgical techniques to apply to various pathologies of primary type 2 mitral regurgitation. Posterior leaflet, commissural leaflet, anterior leaflet, and bileaflet disease.